Talk about hospice, how delaying in treatment and putting patients in hospice actually increases the suffering for not only the family but also the patient.
Yeah, I feel like I don't see a lot of hospice done, in or at least on my unit for the most part. I feel like people are late on it majority of the times, or they just don't even know it's an option. So it's always good to provide the option, and maybe you have like a hospice nurse on your unit, or a palliative care nurse, or like a team that deals with end of life care. Someone should definitely bring it up when it's a good time.
I think it's definitely a touchy subject, and people don't do it enough, especially some patients, some fresh nurses too. I feel like it creates a lot of like uncomfortableness for them. But anyways, guys, those that don't know what hospice is basically a shift from treatment. So normally you're treating the diagnosis, what's going on, the disease, for example, antibiotics. But hospice kind of goes away from that, and you're more focused not on curing, but treating pain, relieving suffering, and having the best quality of life you can have towards the end of your life. So it definitely is different compared to like putting, breathing tubes in, doing pressors. It just kind of and acknowledging what's happening and putting the patient at rest.
It's a really tough concept to grab because the family or whoever's making these decisions has to be ready to take the next step. Like, they have to understand that their relative, their friend, whoever the patient is really sick, and there's really nothing that we could do for them in this point in time that can kind of make them better or cure them. So really, the only way out of the situation is just to make them comfortable. We've did all the measures we can. Now let's try to focus more on comfort. There's nothing that we could solve anymore. We literally took all these approaches, gave all these medications, and didn't help. So it's very difficult because the person that's making these decisions is the one that has to let go of their family member or whoever the patient is to them. It's a really difficult thing to do because you're literally letting a loved one go. Like, you understand that they're not gonna get better. Like, this is basically the beginning to the end.
Like I don't know if it's like this in your hospital, but for example, for me, I noticed that Hispanics have a very hard time letting go when it comes to end of life and things like that. And I feel like they hold on to the family member for so long. I don't know why. I asked once, and they said it's due to them feeling like they're playing God, where they're deciding when the patient should go. But I don't think that's true. Like, have you realized a patient population that does that?
Not necessarily any specific one kind of population, but for me, it's been kind of more balanced. And majority of what I see is people are just waiting till the end, till somebody codes, or they end up passing away with like a status that isn't full code, like a full let, and or like a no DNR as well. And yeah, a lot of majority of people that I deal with missed the opportunity to even do hospice care. I've maybe dealt with hospice, like somebody that transitioned to hospice maybe a handful of times, maybe 5 times in a matter of 3 years, which is way too little. And as nurses, we kind of know the disease process and how it works, and kind of where the end of the line is. And this is where treatment is basically going to stop. We could keep doing the same thing over and over again. It's going to just delay the the ongoing issue, which is the patient's going to die.
And I think the craziest scenarios that I see this happening, just like you mentioned, the patient's going to die, is kidney disease, bro. You have the patients on dialysis. They're usually on dialysis because of diabetes that wasn't managed properly. They start getting foot ulcers. They start getting their freaking toes cut, half metatarsal, so half foot amputation, then going BKA, which is below the knee amputation. And then the worst is AKA, which is above the knee amputation, where you're like literally have no knees. It's just two little wiggly I don't want to
Stumps.
call it little chicken wings. It's like little stumps, bro. And it's so crazy to see patients like that. Usually have a feeding tube as well. They come for recurrent UTIs, urinary tract infections, pneumonia. Like, oh, dude, that shit looks bad, man. That's suffering. I feel bad for that damn patient, and I can't believe that family members let that happen. But that's just my 2 cents.
And there's no telling if the person is in pain. If they're unresponsive, not responding because of their disease process, then they can tell you if they're in pain or not. That's probably one of the scariest things. What if they have this huge amount of pain and we're not doing anything about it because they can't communicate it? So why not to make them comfortable? Like, someone's got to bring this palliative or hospice care issue up to somebody, because a lot of the times these patients or these families don't even know that it's available. And I don't bring it up too often. I know physicians bring it up probably more than me because they're really, really good about that. And a lot of times these families say no because just like you said, they don't want to play God. They think their family member could pull through, and they're just scared to make a decision because that decision impacts their whole life and it impacts the lives around them and whoever has ever dealt with this patient.
Yeah. And imagine throwing like dementia into the scramble, bro. Like these patients have no idea where they're at. Like they're in a complete different reality yet. We just keep them alive. We put them in nursing homes, and they are humans. They all deserve to live. But like these family members are not realizing the quality of life, as we always mention that they don't have anything. They have like no idea like what's going on. Um, but just to kind of stay on track of the topic, right? So hospice, the people who qualify, because not everybody could get into hospice. You have to a healthcare provider, physician has to basically approve you, basically say you are terminally ill and you have less than 6 months to live or less. And the study that we kind of found to kind of prove that, hey, people are suffering more not being in hospice is a study that was published by the General Geriatric Society. They took 16 years, patients 70 and older, 754 of them to be exact, and 40% of them ended up going into hospice the last year of their lives. The medium showed that 40 the patients that went to hospice, they only survived 2 weeks. And just to kind of blow your guys' mind a little bit more, the most debilitating symptoms that these people had were pain, nausea, depression, and shortness of breath. And hospice focuses on decreasing all those symptoms. And their symptoms didn't decrease till they actually started hospice. So the question is are we needlessly suffering for no reason for months on because we're delaying hospice?
That's really crazy to think about. Like, imagine if you're that person, you're that patient, and you're suffering for 6 months. 6 months. You have shortness of breath for 6 months. You barely breathe. Like you feel like you're suffocating every day. And the worst thing about that is you can't say that you can't breathe. You can't say that you're having trouble breathing. You can't say that, hey, I need pain medication. You can't say any of those things. So someone else is making these decisions for you. I feel like people should definitely have something like that in their will. Like if I have 8 months to live and there's no cure for my issue and I'm not responding to any kind of stimuli, just put me in hospice care. I think people might need to start thinking about doing that instead of having somebody else make the decision for them. Because many of the times the patient's idea of what they want towards the end of life is completely different from what their guardian wants or whoever their POA is. Well, if they have a POA, I would hope they at least know what the patient wants.
And see, you work with like LVADs, right? So I feel like LVADs is basically end of life care. Like their heart is not functioning properly. They have this device that sits outside of them that's literally perfusing blood for them, right? Because their heart cannot. Like, do you feel like they're suffering more?
It's not used for end of life care. A lot of times it's used to a bridge to transplant, and majority of the times it's used to add years to your life. Like an LVAD almost guarantees you an X amount of years to live because maybe they could figure something else out, or you could change up your life and you could get put on a transplant list. So it's not end of life care. It's not like they put this thing in you and they say, "Yep, this is everything. This is your end of life. This is how we extend it." No, like there's more. This is takes upkeep. They can't just put an LVAD in anybody, even though sometimes they do put an LVAD in someone that's not necessarily the best case, but it's up to them. At least at least they are at least giving them a shot. It's not anything close to end of life care. There's no LVADs that have ever been put in as end of life care because that's not something comfortable. This is a machine in your body that you gotta be anticoagulated for life. There's so many risks associated with it, so it's not something that you would want for end of life care. It's not used for end of life care.
Okay. Sorry for that correction then. So it's used to promote life, correct? Promote years. Is there an average that that maybe people speculate that you hear how much it extends?
No, I mean, I work in a hospital setting, so obviously I'm going to see like the worst out of the worst. But if you go on like heartmate.com or if you just Google heartmate, it'll tell you their life expectancy. Like some people have lived 10, 12 years. I think a few of the original ones that got the heartmate tour are still alive. So it's I would probably say probably guarantees you like at least a solid 3 years. It's
Okay.
probably like on a lower side. I'm sure people get sick. It just depends on a person. There's different kinds of LVADs. Like I said before, there's people that get it to bridge to a transplant. So eventually that LVAD gets explanted and they get a new heart. So which are you counting those years with the heart as well, or just the years during the LVAD? There's a lot of metrics that go into this. So I'll probably say like a good 5 years.
Okay. And we're just speculating, guys. Like Peter's just talking out of his ass here. Says 5 years. We're not doctors or the people or the company that goes around and knows how this device works in and out. So we're just two nurses talking shit, right, Petey?
Yeah, but I'm sure you could go on hospice if you have an LVAD. Like that's an option, but it just kind of I feel like people are less likely to go on hospice with an LVAD because if they're dying, it's usually like the LVAD's failing as well. So it's kind of more difficult.
Yeah, man. That's dude. Heart failure is a nasty thing. Every
It
honestly,
sucks.
honestly, anything that's in the hospital that we kind of deal with, more of the critical side, it's pretty gnarly. But to kind of summarize this hospice topic, I don't know if you have anything else to add, but I would definitely say, as a nurse, like get your goals and priorities straight when it comes to anything. Like even if it's a regular patient, you always want to ask that question, like, "Hey, going to be a full code?" and explain that. If it's a patient that's coming with like reoccurrent, because we noticed that like, hey, the people that are already kind of like sick, and I don't want to say end of life 6 months, but just kind of like just getting old and reoccurrently coming to the hospital. It's only going to happen more often if it's pneumonia, if it's getting older. So you should definitely always discuss with the family end of life care goals. Like, hey, if this happens, are you okay with everything is happening? Or are you aware if you get this trick, you might be coming in for pneumonia? Just allowing them to understand the options.
I believe that if a physician brings up hospice care, I feel that families and patients are more inclined to accept it because they feel like it's coming from a higher authority, which is people who see doctors as higher authority. They're valuable and highly respected figures. I feel like when a doctor brings it up, is it's going to be brought up in a way that's more beneficial for the patient and family because it's coming through someone that is actually a medical doctor. And I feel like they're more accepted to the fact that the doctor says, "Hey, we did all we can. These are the next steps that we could do." I feel like it's when it comes from his words, it definitely does a lot more benefits to the family and the patient.
I agree with that one. But I feel like we as nurses, we should still kind of push a little bit towards that medium. You know what I mean?
No, of course.
And the last thing that I forgot to mention is people don't know this, that like just because you're in hospice doesn't mean you can't get out of hospice. Like there is a reversal. It's not like a one exit door, like, hey, you're in hospice, then that's it. Some people go into readmission with different things in cancer, and then some patients get back out and go back into getting treatment. Like I've had that happen.
That's actually a key thing to bring up because, like I said, I didn't even know that you could get out of hospice until you brought it up a little bit ago.